Dr. Christine Green attended medical school at the University of California in San Diego and later trained at Stanford University's Family Practice Residency Program. She has practiced complementary, integrative, and orthomolecular medicine in the San Francisco Bay Area for more than 30 years. During that time, she has developed special expertise in the diagnosis and treatment of tick-borne diseases and all the other stuff that can come with them. She is a board member of LymeDisease.org, has served on the board of the International Lyme and Associated Diseases Society, has chaired the ILADS Education Committee, and has spoken internationally on Lyme-related topics. Dr. Green.
Oh, hello. And thank you for being here and learning this stuff. At least it's rainy out there, so it's good to be inside today. So I'm going to talk about stealth pathogens and finding a win-win situation with these bugs we live with. Is there a way to find harmony in these infectious states? And who wants to play? Which of those bugs wants to play? And which of those bugs wants to win, which is when we get into the problem. I love this picture. This exhibits what most people think you have to do to get Lyme disease. You have to be in a northeastern deciduous forest. You have to be standing in the middle of the forest. You have to be stupid enough to not be looking down and looking for ticks at the 4-foot level and looking into the trees at the birds, which are probably dropping ticks on you. But I'm a bird watcher, and I do love this picture. Now, actually, this is a much more dangerous occupation because, as Dr. Stricker mentioned, what's bringing these ticks to us, in relation to us, are the mammals, the little squirrels and little mice. And look at her, this is a bare leg here, right? Whoops, and bare arms there. And the ticks are very excited to see that, So why discuss stealth pathogens when what I'm really talking about is tick-borne disease? And the reasons are the tick-borne persistent pathogens, the persistent infections we have, fall into the category of stealth pathogens. And because the other bacteria, I call them bugs, and other microbes that join those tick-borne infections are also in the category of stealth pathogens. And because the diagnosis and treatment of stealth pathogens is different than the diagnosis and treatment of what we call frontal attack pathogens. And most of your doctors are still working with the theory that there's one bug to find if there are any bugs at all, and they're going to use testing that looks for one bug, and it doesn't work in Lyme, as Dr. Stricker mentioned. So Borrelia uses, I'm going to go through these, it's a busy slide, but I think it's really important for you to know how these bugs act to help your doctors think about them. So incubation period of a stealth pathogen may be indeterminate. What the heck does that mean? That means after the tick bites and gives you something, it may be a month, it may be 2 months, it may be a week before you actually get sick. Most people don't see the tick. 25% of people see a tick anyway. Most people don't get a rash, at least on this coast. But even if you do, even if you're lucky enough to think, what's that, and you get sick in a while, you may not connect the two. So there's this indeterminate time when the bug's just spreading through the body quietly. Indolent or asymptomatic carriage, symptoms appear subtle and viral-like. This is one of my least favorite terms in medicine, which is viral-like symptoms. I was recently at a kind of a think process to try to figure out clinical trials. And there was someone there from the NIH, and she kept saying, but the symptoms are just general, they're non-specific, they're viral-like, and it makes it very hard to take these diseases seriously if you call the severity of what Lyme patients feel a viral-like, non-specific illness. And it's not non-specific. If you really start seeing these patients and you really start asking questions, you see patterns. So engages the innate immune system. This is one of the most clever parts of these bugs, and Lyme is probably the smartest among them. It is a miracle, and I think of this every once in a while as I'm struggling to understand these things or help patients. It's a miracle that life happens. It truly is. And one of the miracles is the immune system. So we have this innate immune system, which is basically a surveillance camera. If a bacteria comes in, if another organism comes in, it has a way of saying, "What's that?" And Lyme has a way of saying, "Nothing, not here." Or, "Actually, you've already seen me. Don't worry about it." Or deflecting things. And it can do it in multiple ways. Or if it gets detected, it can change what it looks like very quickly. It also, we have a secondary immune system, and this immune system is kind of called when the innate doesn't work. And they say, "Look at that guy. Is he a problem? And if so, will you specifically target that guy?" And again, these bugs, Lyme's not alone in doing this, but it's maybe the best guy at it. These bugs really manipulate that system. They actually usually convince it they've already been handled, so don't worry about them, and they calmly spread around the body. Rapid microbial replication may punctuate a recurrent or terminal event. We have had deaths in Lyme, but more often what you're talking about is this disease that comes and goes and is recurrent. Carrier state, what does that mean? It means that some people seem to have this disease and not be sick, or at least have the bug, and the bug can then replicate in them, maybe spread to other people, although we're an end host, so not often, or maybe later cause disease. We don't know until we use data like Lorraine showed to really track what happens over time. There's no natural history of this disease really recorded. Transmission by direct contact in the environment. Well, that's right. That tick is going to find you, or that mosquito is going to find you, a flea. In the case of tick-borne disease, of course, it's the tick. But there are very specific contacts for you. Reservoir, there has to be a specific host that holds the illness. In the Lyme case, it's deer. In Bartonella case, it's cats, any cats, wild or domestic. 40% of them carry Bartonella. So reservoir species, yes, Lyme has it. And finally, and this is important, these diseases seldom give sterilizing immunity. This just happened the other day with a patient. She was a new Lyme patient. She was treated, looked successful. And I said, you know, now report new tick bites and be careful. And she said, wait, I can't get this again, can I? I got this once, right? Now I'm immune. And these bugs are so smart that, nope, you aren't immune just because you have it once and get over it once. So this is a very dangerous animal, as Ray said. Bob Lane showed in the Sonora area that 8 out of 10 of these squirrels carry Lyme disease. And I don't know about your yard, but my yard is full of these guys. Why should we chase the bugs? Didn't we win? So often in the bacteriology area, the thought is that the antibiotics really did handle this, except for those multiply resistant types that people worry about using antibiotics because of those. But I'm just going to read the bottom part. This is from Merrill and Falco. Despite advances that have been made over the past decades in understanding microbial pathogens, more people worldwide still die every year from infectious disease than from any other cause. So that's why we're still looking at them, and because people are sick. So military model vs. evolutionary model. This is a little bit of my talk about can we come into balance with these bugs? Can we cut them down to size and then, even if they aren't eradicated, live with them? The frontal attack pathogens, which Merrill and Falco talk about, are the kinds that are kind of the dummies of the bugs. They get in, they go as fast as they can, they try to outrace the immune system, they replicate as fast as they can. The stealth bugs are much smarter. They come in, they look around, they want to find a good place to live, they hide themselves from the immune system, as I said, and they kind of check out the neighbors too, because they're going to live with the neighbors and they're going to recruit them to be part of the infection along the way. In this model, in the evolutionary model, the infectious agent, the system is kind of pushed towards finding some sort of peace. And this leads to an integrative medicine model of saying, let's make the human as healthy as we can. Let's make the system as good as we can for the human. There'll still be bugs that figure out how to get by that system, but that's kind of the basis of integrative medicine. So where are the bugs? 99% of all bacteria live in biofilms. What does that mean? Well, Dr. Stricker told you that biofilms are like sludge. They're like this sticky stuff, same stuff that's in your joints, actually, hyaluronic acid. And a microbe wants to live in community as much as anything else. All life seems to want to live in community. Most biofilms are quite complex. The growth starts with gram-positive bacteria, then the gram-negatives are brought in, then they use yeast to kind of build the walls of the structure. Yeast is kind of long rods, and those usually are involved in biofilms, especially in the bodies. And they have different parts of the biofilm. There are parts where the aerobes live and anaerobes. Now that's important because Lyme happens to be a partial anaerobe. It doesn't like oxygen very much. In fact, that's how it chooses partially where it likes to go in the body, into the brain, into the joints. The heart has a lot of oxygen, and occasionally it likes to go there too. pH can vary in a single biofilm, and anyone who's a biologist knows that a 3 to 11 pH is remarkable. If our pH varies by much more than 0.4, we're gone. So there are protections in that biofilm. And most mixed species biofilms are more stable than single species. So it looks like, as Dr. Stricker said, Lyme can form a biofilm. And that has been shown by Dr. Shappy, Dr. Zhang, and Dr. Fry in his lab believes he's stained them. Are they important? Do we really need to break them up? We certainly aren't going to break up our biofilms because our biofilms are protecting our good bacteria. They're living happily in community with the good guys. Do the bad guys figure out how to invade our biofilms and thus be safe? Maybe, and we'll talk about that a little bit. So co-infections, most bugs live in community. It's better to be in mixed communities. It's more stable to be in mixed communities. So ticks are sewers of infection. Lorraine and Ray said that in a paper, and others have probably said it. They're full of different bugs. So when you get a bite by a tick, you're not just going to get Lyme. And how do those bugs cooperate? We believe they do at some level, because if you get Babesia and Lyme, it's harder to get rid of either bug. If you get Ehrlichia and Lyme, it's harder to get rid of either bug. That's probably true with if you get this infection in Lyme or that infection in Babesia. But those studies, as Lorraine showed, they're very hard to do. These microbes play together, maybe live together, maybe invade our biofilms. Infections with 2 or more microbes are harder to find, and we don't know how to measure them. We don't know how to find them. So what we're looking at, and this is not isolated to Lyme, this is all over the infectious literature. In 1880, a very famous guy named Dr. Koch made a postulate that said, oh, one bug, one disease, here's how you prove it. You get the bug out of the sick person, you culture the bug, you put it into an animal, it gives the same disease, you take it out again, you do that all over again. If that happens, then you've proven that organism causes that disease. The problem is we've got 2 or more infections going on in Lyme. We've also got a very clever Lyme, which Dr. Stricker showed, with different morphological forms. Maybe that's the whole story. Maybe the co-infection is a big part of the story. Once you have a co-infection, we don't know what criteria to say, yep, you got it. You've got Babesia, you've got Bartonella. And what you most often hear from doctors who really haven't studied this area is, oh, don't worry, that's a past infection. That's in the past. But we have case reports of people who've had two different infections at once, and indeed, they don't show the CDC criteria for positive infection, which is what we call a 4-fold serologic change. So you have an antibody and it changes 4 times. And then you can say, yep, that's an active infection. But that doesn't work with co-infection. And hey, guess what? We haven't had the studies that tell the doctors what does. So how do you define that? Symptoms of simultaneous co-infection. You know, if you have Bartonella and Borrelia, I'm sure any of the Lyme patients here have read about Bartonella causes burning feet, and, you know, Borrelia causes memory impairment. But the truth is, when you start mixing these up, we aren't sure what the mix is, what it looks like. We aren't even sure what the individuals are. So laboratory measures, 40%, the gold standard for bacteria, to prove the bacteria is there, to prove it's active, is to culture it, okay? The problem is, it's really hard to culture Lyme. It takes maybe 2 months to prove you don't have a positive culture, and even if it's not positive, you can't say the bug's not there, because it's seldom in the blood to be found to culture, and it's seldom in the cerebral spinal fluid, which is the other thing we can culture. 99% of environmental bacteria can't be cultured, which is interesting in itself. So that most bacteria in this world, we have 500 different kind of bacteria in our gut that belong there. We can culture maybe 30 of them, maybe 40 now. So, okay, so let's look for the DNA of the bug. Then we don't have to culture. We're just going to do a PCR, which usually looks for DNA, can look for a specific protein. Let's do it that way. The problem with that is it's highly specific. Get a positive PCR to any of these bugs. I would turn as a doctor and I would say you have an active infection, okay? But it's not very sensitive. Why? Because the bacteria are often not in the blood. They're often up there in your brain or in a tissue layer. They're tissue-based infection, most likely. So you can keep trying to take blood because they have to come out of that tissue to replicate. But if you don't know that kind of pulse, that relapsing timing, it gets very expensive. You can lose a lot of blood, and it's a shot in the dark. So then we go to antibody titers. Antibody titers and lymphocyte transformation tests, which I didn't put on here because they're hard to get in this country, measure your response to a bug. It measures your specific immune system response to the bug. And then what you get is you get into all sorts of controversy about, well, wait, if you make an antibody, like an IgG antibody, that's part of the miracle of our immune system. It remembers forever, so that IgG antibody might stay there to protect you from the infection. So you get in arguments about what's active infection, what's not. What's interesting in Lyme is that Lyme can break the ability of the body to make IgG. Normally, when you first get sick, you make IgM. You do that for a little while. It's strong and it's fast, but you get tired doing it. So you switch that over to an IgG, and the Lyme can destroy the lymph node that does that. But again, the criteria for diagnosing Lyme, if you're a doc who's not like me and hasn't read all this stuff and done this for 30 years, is to open up something called UpToDate. So your doc's a good doc. Maybe this is Lyme disease, open up UpToDate, and it says, okay, you do an ELISA. Maybe magically your ELISA was positive, which it won't usually be in late Lyme. And so you get an IgM positive Western blot, but it says if you're sick for longer than a month, you can't count the IgM. That's what UpToDate is going to tell the doc. That's wrong. And I won't go through all the reasons it's wrong, but we have a real problem with laboratory measurement for Lyme. So no test can rule in or out Lyme disease. That is in the ILADS guidelines, which I'll show you at the very end. So how do you diagnose Lyme? We look at the patient. I have been in practice 30 years. I was taught an exam was really an important part of my medical care. So you start to look at the patient, and we look for physical signs of the disease as well as a history of the disease. I'm just going to run through kind of how we do this. So Bartonella, these are Bartonella symptoms in the literature. We have sleep disturbance, we have fatigue, we have arthralgia, achy joints, we have dizziness, we have headache and seizure, we have memory loss, myalgia, eye pain, depression, doesn't this sound like Lyme to you? Shortness of breath, that's babesia, and muscle weakness. But all those have been confirmed as being Bartonella symptoms. So your doctor is going to ask for symptoms. When did they start? How did they develop? Do they stay there all the time? Are they gone now? Do they change? And here's a sign that we think is a Bartonella sign. There's a lab called Galaxy, that's a specialty Bartonella lab, that has been biopsying. These are called stria, which means stripes in Latin, I believe. So Bartonella stripes, we've been biopsying them and sending them, and we have been finding Bartonella in those stripes. So we think this is correct. But in any case, this isn't a normal rash. These are not stretch marks, right? So you look at the patient. Mycoplasma symptoms, look at these. Arthralgia, myalgia, cognitive difficulties, insomnia, 3 out of 7 people. Gulf War syndrome has been ascribed to mycoplasma, chronic fatigue syndrome. 40% of community-acquired pneumonias, not argued. Fever, fatigue, Stephen Johnson. Encephalitis, encephalopathy, that's Lyme. Aseptic meningitis and polyradiculitis. Whether mycoplasma is tick-borne is argued. It's certainly found in the ticks. If you got a bug that sucks blood, it's going to suck up whatever's in that blood. But again, so here's something I see often in my office. This is called livedo reticularis. It is seen in mycoplasma. Personally, I think I see it in my Bartonella patient, but a lot of my Bartonella patients have high mycoplasma titers. And this will be a patchy, lacy rash that appears frequently. And when I notice it, many patients go, oh yeah, that has started to happen, you know, and it'll be here and it'll be there. So again, looking at the patient is important. Babesia symptoms, well, the ones in the literature for acute babesia, sweats, chills, it really is like malaria. It's a parasite that attacks the red cells, just like malaria, same class of bug. But in the office, we see the same thing a little bit. We see sweats. I see people who are so cold an electric blanket, piles of quilts, won't do the trick. Air hunger or breathlessness. And, you know, it's funny, when people get babesia, they often have a breathing, I call it a clearing breath, and little kids do it. Like, I had a 6-year-old in there and kept going, and his mother said, ever since that tick bite, he's been doing this. You know, it makes a diagnosis for you. Nausea, lightheadedness, irritability, and rage. Irritability and rage, I think that's a Bartonella symptom. So stealth treatment is different. So how to make the diagnosis is a clinical diagnosis. We use the laboratory to guide us, but it can't rule in or out these bugs. We don't know enough about co-infection. We actually don't know enough about Lyme and its different morphological forms in terms of immune response. There is a hot and heavy interest in getting better diagnostics, and they probably are coming down the pike. So, what about stealth treatment? What's different about stealth? And again, the problem is most of infectious disease is still working on Koch's postulates from the late 1800s. So most of them are going to treat only with one drug, right? And you can't do that. I assure you, if you go into the literature for almost all of these bacteria and microbes, it will say, you don't use one drug. You can't use one drug. You can't get them. Why not? Because the stealth bug's all over the place. It might be in the brain, hard to get drug into the brain. It might be inside a cell. It might be outside a cell in tissue. And you have to get antibiotics that target all those places. Changing shape, Dr. Stricker mentioned this. Cysts have been described, which means you have a little sac with a bunch of Borrelia in there. Persister cell is now the word that is used in microbiology. And you know, if the going gets bad, a little doxycycline's coming down the bloodstream towards that bug, it's just going to change its shape, at least some of them, and the doxy's not going to kill it. And then do we need pulses or courses of antibiotics? And Dr. Stricker mentioned Dr. Lewis. He's been experimenting in the test tube with pulses of antibiotics. So to treat these, we reduce the pathogen load. We use pharmaceuticals, we use botanicals. Lorraine showed you that herbals are maybe considered by patients the most successful treatment of the alternatives. Chemicals, colloidal silver has been shown to augment the work of antibiotics. That's a Johns Hopkins paper. Iodine may help. And then the other idea more and more out there is let's outcompete the bad bugs. Now it's a little hard, but there's a lot of interest in our gut bacteria and the human biome and making sure that we keep it healthy and that it combat other things for us. And indeed, a healthy human biome helps your immune system and also keeps down problems like yeast, etc. So stealth pathogens have persister forms. Each form must be adequately treated. Treatment has to be applied over time because these bugs are really slow replicating. So if you're going to use an antibiotic, I don't care if it's a botanical or if it's a pharmaceutical, you kill the best when the bug's replicating the fastest. In general, that's true. Dr. Zhang et al. Is working on finding treatments that will kill those quiet little persistent cells. And then manipulating the biofilms. This is something that's hot and heavy in the literature. It turns out in the biofilms, they're like science fiction. I wish I had a picture. They're like blobs. The biofilms in EM, they're all these organisms in this jelly structure, and they have little filaments that communicate between, they talk to each other. And they talk to our cells too. And one of the things that will happen in a biofilm, it's called quorum sensing. All of a sudden, all the bugs will go somewhere. They all go, it's like chow's on down there, you know, and uh-oh, the bad guy's coming, go over there. And we have started to experiment with how to signal those things for the biofilms. Again, we have to be careful because biofilms are in general a good thing. We want our biofilms to be healthy. So if the bug's in the spirochetal form, if the Lyme's in that, probably a single antibiotic will work. So if you're early, if you haven't seeded other tissue, a single antibiotic long enough may work. In the biofilm, maybe we'll manipulate these quorum sensing. Something that bacteria can do that's being looked at is as soon as the doxycycline gets into the bug, they have a pump to get it out of the bug. And it's called an Efflux pump. And we're trying to disable those. A drug called tigecycline, which has been pretty successful, does that. And then I just mentioned maintain immune function because it's important to think about that. And I have a slide for that. But even in terms of giving your antibiotics, you have to think about what the immune function's doing. This is really important, and I mention it not in passing, but to say you have to maintain your fitness. Even if you're really, really sick and all you can do is tighten and let go for 2 minutes 3 times a day, if you can maintain, you can't build fitness when you're really sick, but you have to do that to maintain your circulation, to get the white cells in there. And you have to maintain your mental fitness too, wherever you can, whatever you can do at that time. You have to control inflammation, not squelch inflammation, but control it. Inflammation is how generally we kill bugs. It's how generally we repair tissue. So you want to allow a certain amount of inflammation, but too much hurts too much, and too much also blocks your antibiotic from getting there. So we want to support the immune response. You want to laugh. So modulating inflammation. I think Dr. Stricker mentioned this. One of the things that is sometimes said about giving these long-term antibiotic regimens is that they're actually anti-inflammatory. So you're actually just decreasing inflammation so the person feels better, okay? Ceftriaxone, that's the IV most common for Lyme. Tetracycline, doxy is probably your most common antibiotic. Macrolides, which are zithromax and clarithromycin, and the quinines. Well, it's very interesting, but some of drugs that we use for other things are antibiotics. Let's look. Quinines kill parasites. They have been used and are still used for malaria in certain ways. Many of your protein pump inhibitors, those antacid like omeprazole, they can kill some bacteria. In addition, some of your antifungals are antibacterial. So it has been frequently said that the antibiotics we use to kill tick-borne disease are anti-inflammatory, but I've never heard an argument that some of the drugs we use to control the symptoms of the disease are antibacterial. And if you notice the last one, imipramine, phenothiazine, serotonin reuptake inhibitors, those disable the bacterial pump. This is very interesting to me because some antidepressants work in people with Lyme. Sometimes they herx on them. Maybe this is why. And maybe we need to really think about when we have infection and when we have inflammation caused by autoimmune disease. Efflux pumps, just to mention, berberine, which is extract of golden seal leaf, it disables one of the bacterial pumps. Palmitine, which is in Coptis, I don't know if that's Chinese trefoil, and it really works sometimes against Babesia very effectively. It disables some of the bacterial pump. So there's a great deal of interest in these botanicals in the pharmaceutical world, combining them with the antibiotics to make them more effective. And this is perhaps why those botanicals are so effective. So I just want to mention that we do need to support the immune system, but not always at the beginning of treatment. Many people who get Lyme have great immune systems, and the Lyme gets them, and the Lyme starts manipulating it. Cut down the pathogen load, cut down all those bacteria, and that immune system's going to come right back. When you give an antibiotic, you're simply aiding the immune system. What still cures a patient is the immune system, not the antibiotic. Mast cell activation syndromes, I don't know how many of you know that term, but that's something we really have to look at. Sometimes the immune system is triggered so much that you end up with these tissue-based allergic cells, and pretty soon you can't eat but 6 foods because everything triggers a reaction. You can't smell anything, because that'll trigger a reaction, and we're with that. So I just want to mention the evidence-based guidelines for Lyme disease. These are on the Guideline Clearinghouse. These are the ILADS guidelines. Lorraine Johnson was a major author on these. If you have a doctor who's cooperating and wants to learn about Lyme, give him these guidelines. They are graded. They're according to the Institute of Medicine. They are amazing, and they will help get people treated. Sources, there are many. I just put 3 here. If you want to explore botanicals in Lyme, I like Stephen Booner. He's scientific. He gives you the background. He's also a really good herbalist. Richard Horowitz, which you maybe all know, has written a book that puts together both the pharmaceutical and the integrative, and then the guidelines. So thank you very much. Sorry I didn't have pictures.